to introduce now our two speakers, two very distinguished speakers, to come and join me here on the screen. Dr. Mohammed, Dr. Dan, maybe if you now open your cameras, open your video and your sound, and we can introduce you here live to our crowd that is listening and joining us today.
Hello.
Hello. Thank you so much for joining us. So I'll start here with Dr. Dan Dumitrascu. I hope I pronounced that right.
Perfect.
Yes. You are a professor and head of the second department of internal medicine at the University of Medicine and Pharmacy in Romania and chairman of the UEG National Society Committee. You're an expert in the field of gastroenterology with a focus on neurogastroenterology, something you will also touch on later today, and psychosomatic medicine. You have been the co-author of 220 papers in Romanian and international journals, and are also a member of the Rome Foundation Committee. All of those things today you will, I think, touch upon a little bit today. Welcome to the iGES webinar. It's a great pleasure to have you here.
For me too.
Okay. Dr. Mohammed Rashid, hope I got that right in terms of pronunciation. Thank you very much for being here with us. You're a consultant in gastroenterology and a hepatologist, assistant professor in gastroenterology at the University of Jordan, Amman, a member of the World Gastroenterology Congress Committee for Global Clinical Guidelines, and also a member of the Jordan FDA. It's a great pleasure to have you here. Thank you so much. And I really look forward to following your discussions today. So without further ado, I do not want to speak any further really. And I would like to start with Dr. Dumitrascu, maybe to share your screen and to head it off. Thank you so much for being here.
Thank you, Fabian. Good evening, everybody. I'm so happy to have been given this opportunity to talk on one of my favorites, IBS, in front of my colleagues from Jordan and Middle East. The agenda of my presentation will include an introduction with greetings to our hosts, and then I will discuss conceptual changes in defining IBS. I will show you new epidemiological data, some are brand new, on IBS and other functional disorders, diagnosis criteria on IBS, and you see some changes in diagnosis criteria has produced some changes in epidemiological prevalence data, and of course in conclusions. But I am happy to introduce you first my city. Here is the kilometer 0, the square in the city, in my city. Here on the map of Romania is my city and my university in the northwestern part. You see here the building of the new head office, and here behind me on the back screen, small tower of the university. And here is the hospital where I work. It's a very nice Art Deco hospital. But I use this opportunity also to greet my Jordanian colleagues. Probably you know that there is a Jordan Association of doctors who graduated in Romania, several thousands, and they had yearly meetings. And I had the opportunity to attend the third Jordanian Romanian conference 8 years ago. And this was the same time the first conference of medical graduates from Jordan in Romania. And I had the honor to stay during the opening just close to Her Royal Highness, Princess Noor, and close to high authorities of Jordan. It was a not forgettable meeting. And beside this, we have alumni from Jordan. And one of our important alumni was Dr. or he is still Hamoudi, Wasim Hamoudi, who is in the board of the journal of our university, which is indexed on PubMed. And with whom we published a paper, look, many years ago. So I want to say that the bridge is largely open between Romania and Jordan and Middle East. So I have the pleasure to continue with the scientific matter of my lecture. And what is new in IBS? What changing from the conceptual point of view in respect to this condition? And I will start with two Arabic proverbs, because it's important in our approach to IBS patients. Good health is a crown worn by the healthy, then only the ill can see. And the other one is from Avicenna or Avicenna. The knowledge of anything, since all things have causes, is not acquired or comprised unless it is known by its causes. So when we approach IBS, we have to think to the truth of these words. You know that the gold standard for functional gastrointestinal disorders, recently renamed disorders of the gut-brain interaction, is the work of Rome committees, founded 1989 in Rome by the late Professor Torsoli, but led till last year by Professor Drossman from Chapel Hill, and now from Jan Tak from Belgium. You see here the last and the forelast edition, Rome 3. You see on the cover written the functional gastrointestinal disorders. In the Rome 4, issued 4 years ago, the subtitle is different: Disorders of Gut-Brain Interaction. This is a conceptual change given by the progress of our knowledge on the nature of these medical conditions. In our practice, we see mainly gastroenterological patients, but some of you are also have other specialties. And we know that maybe half of the patients we see have organic conditions, which are verifiable by biomedical assessment, while others suffer without an obvious organic or biochemical condition. These are called functional. The wrong conception is that if a symptom is not validated by investigation, this is a psychiatric condition. It's not for us. It's not for us. But the current conception is that according to the biopsychosocial model, and we'll return to it as soon as possible, symptoms can occur even in the absence of positive findings during investigation. The Rome 3 edition, was very useful indeed, but had some shortcomings. The term functional gastrointestinal disorder was not precise enough. We didn't help too much in approaching the disorders. It was an exclusion criteria. We had to rule out any other conditions before arriving to the true diagnosis. The criteria were oversimplifying the illness. And obviously the diagnostic pathways were not always precisely specified. Therefore, we have to consider new aspects in the field. First, the quest for new comprehensive epidemiological data. Then the occurrence of the interest on microbiota and the accumulation of information about its role, protective or deleterious in the gut. Then the quest for new biomarkers. We do not have any perfect. Then the need to identify phenotypes. We treat patients, we do not treat diseases. And of course, the advent of new therapeutical approach. So changes were needed, and therefore paradigmatic changes also happened. First, we can use the word or the expression functional gastrointestinal disorders, but we prefer disorders of the gut-brain interaction. disorders of the gut-brain interaction. These are common disorders characterized by persistent and recurring symptoms occurring as a result of abnormal function of the GI tract and not caused by structural or biochemical abnormalities. Which functions? Motility, hypersensitivity, mucosal defense, immune defense, gut microbiota, permeability, CNS, central nervous system processing. These are the starting point for the new approach in Rome 4. We preserved from the Rome 3 the topographic classification, the age classification, adults, neonate, toddlers, child, adolescents, and the biopsychosocial model. Here is the topographic classification of the disorders of the gut-brain interaction, functional gastrointestinal disorders, and IBS that I focus on it today is here in the bowel, is category C. And the biopsychosocial model, here is a version written with my colleague from Cluj, Teodora, relies on the work of George Engel, the psychiatrist from the United States, who showed that actually a disease is produced by the interaction of psychosocial factors interacting with environmental and internal factors, including actions on central nervous system, on the enteric nervous system, which developed symptoms, and the symptoms have outcomes and deteriorate health of quality of life. Therefore, the psychosocial model is the backbone for a correct approach of the disorders of the gut-brain interaction, including IBS. Therefore, we can define now IBS as a disorder of the gut-brain interaction of the bowel, characterized by abdominal pain and abnormal defecation. As you see, it's a positive diagnosis, is no more an exclusion diagnosis. And new criteria were adopted, therefore new epidemiological data have to be searched. Here are the well-known by you diagnostic criteria for IBS. So recurrent abdominal pain, on average at least 1 day per week, not rarely, with defecation disorders in respect to rhythm or form of the stool, and the well-known chronological criteria which change from edition to edition of the Rome editions, 6 months from the onset, but 3 months of active presence of the disease. Not a 2 months diarrhea can be labeled as IBS. And IBS is not a monolithic condition. It has several subtypes with constipation predominance or diarrhea predominance, or alternation of constipation or diarrhea. It's called mixed, unspecified. And then there are alternators, maybe 1 year constipation, 1 year diarrhea, and so on. Alternators that are actually mixed cases with longer period of alternance. And then we need to look for new epidemiological data on IBS. And here you see me when I was in Petra looking through the caves into a cave. So we have to look on IBS in the world. The data we had relies mainly on this highly cited meta-analysis of Lovell and Ford from UK, almost 10 years old. And here you see how many countries have higher prevalence of IBS, 15 to 20%. But this data are not so reliable. They are sometimes based on small studies. For instance, data from Nigeria. Nigeria had 30%. It relies on actually on single center, showing 30%. This is not conclusive for what we need to know about Nigeria and about even of the whole continent. So these were the data 8 years ago, almost 10 years ago, but now we needed more. And in order to know, the Rome Foundation started a study but not before showing in our paper in GATT, first author was Ms. Perber, that global prevalence in adults remains elusive because this is such a high discordance of data. And therefore, it was the need to start a very pragmatic study, which was published ahead of print in summer, but now in January occurred on paper first time. It's a fantastic worldwide study on worldwide prevalence and burden of functional gastrointestinal disorders, the old name, results of the Rome Foundation global study, just published in Gastroenterology in January, but again online in April. And you see here the participating countries. Romania was one of them. From Middle East, you see Egypt, you see Turkey, you see Iran, you see Israel, so several countries around, but you see many other countries were missing, even Austria. This was a large study, including internet survey in 24 countries, household survey in 7 countries, like India, or both methods like in China for other countries. So you see really a global country. And now we have the true prevalence of functional gastrointestinal disorder. If we put together all the possible functional gastrointestinal disorders which have been identified via this survey with the limitations we all assume, you may see that in the largest part of the world, 40% of the population has diverse functional disorders, or better called disorders of the gut-brain interaction. So it means that almost half of us or of our patients might have other functional dyspepsia or IBS or esophageal hypersensitivity, like hypertension or so many other very common conditions. The study relied on the investigation of almost 50,000 adults. From Romania were almost 2,500. This is an impressive study. And the people had to fill on internet the Rome criteria questionnaire, but they also have been surveyed by some questionnaires looking for quality of life on demographic or some selected medical history. Of course, organic conditions have been ruled out in the methodology. And here you see some of the results available. And you see here where the blue arrow is, the new data on IBS. You see here, altogether, 54,000 investigated people, almost half females. Here is the age group representation. In some countries, in the internet survey countries, elderly were underrepresented because, like in my country, not all age people are using internet. And what you see here is different what we believed before. So you see that according to Rome 4, IBS is 4.1 with confidence interval between 3.9 and 4.2, while in female it's 5.2 and in male 2.9. So this is the total, and then you see their data on subtypes of IBS. So actually we have to accept that IBS is not 15–20% that we believed 8 or 10 years ago, but it's true, but it's not as frequent as we believed. The most common is the functional constipation. And I put here an arrow for Egypt because I consider the data for Egypt are more similar to what you have in Jordan. And you see that in Egypt, the any functional gastrointestinal disorders are almost half of the population. With my colleagues, you can confirm this. Dyspepsia is 12%. IBS, according to Rome 4, is 7.6. But with Rome 3, with different countries, it was double. So the previous data from the 4 meta-analysis were maybe true with the Rome 3 criteria, but the new Rome 4 criteria are more strict, more specific Therefore, the prevalence is somewhat smaller. However, don't worry, there are a lot of patients for us with IBS. We should not be angry that our number of patients with IBS decreased, actually. And here we are comparative data in internet survey countries and household survey countries, showing that in Rome 4, the total figures are somewhat smaller than with Rome 4. But those who remember, the same happened in Rome 3 when they occurred compared to Rome 2 criteria. Rome 3 was more restrictive, and now Rome 4 is even more restrictive. Therefore, I believe it's more accurate. Here is another figure from the gastroenterology paper, looking in a graphic manner in internet countries and household countries, the prevalence of functional disorders. And you see here that functional constipation is the most common, but IBS is really ubiquitous presence. But the prevalence is not 15, 20, but it's around 5, 4, 7, and so on. But remember, IBS is not alone. OBS, you know, overlap with other disorders of the gut-brain interaction. And here is in preparation another manuscript which is submitted for publication. But here are data from the abstract presented by Amis Perber in UEGW online in October. The same group, more than 50,000 participants in 26 countries, they looked at high frequency of overlap syndromes between esophagus and bowel, gastroduodenal and bowel, biliary and bowel. And the conclusion is that DGBI are universal association because pathogenesis are more or less similar. But people who have more overlapping conditions, I mean the DGBIs, have a more deteriorated quality of life, and they have worse psychological comorbidity. So severe cases have comorbidities, I mean several DGBIs, not only IBS. On the diagnosis, and I can recommend you this book that just occurred a few weeks ago by Douglas Drossman and Johanna Rudy, Gut Feelings for Doctors and Patients. We have to emphasize that the diagnosis should rely in continuation on clinical data, requires a limited number of investigations, do not enter in the game of the patients who require investigation and CTs and colonoscopies and so on. We should use the biopsychosocial paradigm. We should identify the subtypes, individualize the diagnosis, and using the multidimensional clinical profile, we have to look for a personalized therapy, and we have to look for particularities in women. I understand some colleagues are gynecologists. Remember that IBS subtypes are not always stable, and the most unstables are the mixed one, as showed also one of my colleagues. That IBS is one of the DGBIs of the bowel beside functional constipation, functional diarrhea, functional abdominal bloating, and more recently, opioid-induced constipation. The first, I call them usually incomplete forms of IBS. We use to identify the stool, the well-known Bristol stool scale form. Unfortunately, some patients claim they have constipations, but they show type 3 or type 4. Is not always what the patient is reporting is validated by this Bristol scale stool. In order to label a subtype as constipation or diarrhea predominant, we look for the 25% threshold in the number of bowel movements to say it's constipation, is mixed, or is diarrhea. And then the Rome 4 developed diagnostic algorithm in order to arrive to subtypes identifications. So we start with the patient's history. Then we look for the checkup. We look for the alarm figures that you know very well. And if they are present, we check for an organic disease. If they are not present, we use a limited screening test, like looking for blood, for inflammation, calprotectin, celiac serology. If normal, we go for IBS, we look for the stool and classify the IBS subtypes according to the stool. If abnormal, we go back to look for an organic condition. And here are the criteria for incomplete formos IBS, like functional constipations, like the true IBS. Functional constipation has the same chronological criteria, 3 months of activity in last 6 months from the onset. But of course, defecation should be disturbed. In 1/4 of the occasions, we look for the Bristol stool form scale 1 or 2, and actually otherwise we operate with the same system. For functional diarrhea, of course, diarrhea in more than 1/4 of conditions, chronological criteria, same. What is missing, like in constipation, the abdominal pain. That's why it's not an IBS, but an incomplete form. The abdominal pain is missing. Only bowel movements are disordered. And then we have abdominal bloating and distension. Bloating itself is not a criteria for IBS, but some people may have at least 1 day per week bloating per abdominal distension, at least in the last 3 months, in at least 6 months, sometimes with pain or not, but without criteria for IBS, not criteria for functional diarrhea or constipation. And then, of course, we have unspecified functional bowel disorders, those who are not qualifying in each of the previous one. And in the same graphic manner, the Rome Foundation developed algorithms for the diagnosis of functional constipation. As you see here, it's following the algorithm for IBS, except again, we do not go for pain. And in the same way for functional diarrhea, again, starting with symptoms, with a limited checkup. And we can, if alarm signs are not considered, we can go for functional disorder of gut-brain. Colonoscopy is not necessary in people younger who have no alarm signs. Every findings, there are papers showing this. IBS patients with colonoscopy who do not have indications for alarm signs or are not older than 45 or 50 have the same findings like the people submitted to preventive controls of polyps. It's the same findings, like in the general population. And the same, the functional bloating has also the same algorithm. We start with the symptoms, look for the history of the patients, look for the possible alarm signs. If they are ruled out, then we look if the Rome criteria failed, and you can quite correctly identify bloating. But in order to go to the patient and not to the disease, Rome Foundation created these multiple dimensions clinical profile categories you see here. That's very good when we approach this patient, manage the patients. We look for categorical diagnosis. So what is IBS? Clinical modifiers with constipation, impact on daily activity, severity. Psychosocial modifier, for instance, with anxiety, physiological features, for instance, with calprotectin or post-infections. Here are examples from the slides kit of the Rome Foundation that you can also buy on the internet. And here is a case of a female nurse, 45. I do not have the time to read it all this. But anyway, if you look for a patient, we look to the history, we label the patient as having IBS, the categorical diagnosis, clinical modifier, IBS with diarrhea, impact on daily activity, moderate, psychosocial modifier, not in this case, physiological feature and biomarkers, not in this case. But subtypes is not enough. We have to go to personalized medicine, and we had an European program where I joined it, led by a junior inter-European project, phenotypic of subjects for large-scale studies on patients with IBS. So we have in neurogastroenterology let's say, the pathway to phenotype IBS patients. Phenotyping is important. You see here my twin sister. We have genetical similar package, but totally different phenotypes. The same with the IBS. And here is, I like what Fernand Marin from Barcelona said, nothing resembles less an IBS than another IBS. It's a joke, but it's a reality. And subtyping IBS, it's important because we can lead the therapy according to subtypes. And Dr. Mohamed Rashid will talk about this very well. You see, if the patient has IBS diarrhea, the therapy is different from IBS constipation or from IBS mixed. So diagnosis is the background for an appropriate individual therapy. Checking for biomarkers. Here, together with a fellow, we look for so many biomarkers in serum or in feces, and none is perfect. You know the story with the vinculin some years ago. We do not still have a biomarker, but we rely very well on clinical symptoms. The role of stress, you know how stress, these are classical studies by Shin Fukudo in Japan, how stress is activating the motility of IBS, but it's not also a diagnostic stress, and we cannot perform colonic manometry in patients. We looked with another colleague of mine on personality traits, and you see here we added more than 30 factors, psychosocial factors connected to IBS, and the most important are catastrophizing, anxiety, and somatization. These are most important. You see here anxiety and depression have risk for IBS patients. The genes are also involved, as I said, and even psychiatric changes in IBS have, you see here, a lot of genetical predisposition. Recently, very recently, the American College of Gastroenterology recommended the following in respect to IBS in their guidelines: serological testing for celiac disease for diarrhea type, testing for fecal calprotectin or lactoferrin for diarrhea type, anorectal physiological testing, balloon expulsion test or anorectal manometry for constipation type. And remember, strategy of positive diagnosis and not exclusion diagnosis. As I said, IBS or DGBI, IBS is no more an exclusion diagnosis, but true positive diagnosis. And again, they do not recommend colonoscopy in younger people without suspicions, do not recommend routine food allergy testing, do not recommend, this is en vogue now, testing for enteric bacteria. IBS is more frequent in women, pain is more frequent. Pain is not related to menses, more frequently diagnosed with endometriosis. Women are more frequently submitted to abdominal or gynecological surgery. Maybe in some women, the physical abuse may play a triggering role. Pregnancy improves the IBS symptoms, and hormonal supplementation does not influence IBS symptoms. These are information for colleagues, gynecologist colleagues. And here is, I can recommend a nice study showing the role of sex hormones in the gut-brain interaction, a nice study from Korea. The advantages in using ROM4 criteria is an accurate method, allow rapid management of the patients, are cost efficient and avoid unnecessary testing, and have a low risk of misdiagnosis. In conclusion, IBS is a disorder of the gut-brain interaction. The ROM4 criteria show a lower global prevalence than previously accepted. The diagnosis relies on clinical symptoms and on subtypes classification, looking just to individual characterization. There are 6 particularities in IBS, and diagnosis is starting point for therapy. Of course, I thank you for your attention. Here are our flags. I would mention that the European Neurogastro meeting was scheduled in Bucharest in September due to COVID. This year will be virtual, but in another 2 years, we'll have back in Bucharest the European meeting of Neurogastro, and you are most welcome. And now some questions. Yes. Question 1, what is the global prevalence of IBS according to Rome 4? You have here several figures. Do I have a correct answer, or shall I say if I'm correct? I would put yes, very well, but according to Rome 4, I would say even smaller. Have you seen the data in Egypt is 7.6, while in Rome 3 was 14. So in Rome 3 was correct, but now these data are, I would put B. Question 2. When do you recommend colonoscopy in IBS? Always, you never know. In patients with familiar incidence of colorectal cancer, in IBS diarrhea, in patients over 45 and with alarm signs. Perfect. I appreciate. I'm very happy. And the next. Abdominal pain in IBS has the following pattern. Improves after defecation, is impaired by defecation, may be associated with bloating, may be associated with muscular pain. Perfect. Actually, the last point was tricky. When I said muscular pain, I mentioned fibromyalgia. And you know that fibromyalgia is a functional conditions commonly associated with IBS. I appreciate very much your answer. Thank you so much. And I guess this was my lecture. Maybe it took a few minutes longer than I should have to talk. I hope I didn't embarrass you with this. I appreciate your time.
Dr. Dumitrascu, thank you so much for this wonderful presentation. I encourage everyone to pose your questions now. And while you do this, I have to apologize once again, Dr. Dumitrascu, you did not notice this, but we're having a lot of technical trouble here. We are in touch with the support team of Zoom, the technical provider here, the software provider that enables this webinar. They are aware of this problem. There seems to be an issue, if you try to register over the phone. So a lot of you could not get in the first time. Those obviously that listen to me now, I can only apologize to, and we are working on a solution, but it seems we are facing serious trouble that are surely beyond our control right now. So I would like to...
Sorry, Fabian, but I think they will get certificates even if they could not link.
No, of course, we will take care of all of that. And also we have everything recorded and will provide your presentation, Dr. Dumitrascu, on Facebook, on YouTube, and all of that will be available and be recorded for eternity. So, but let's now move on to the Q&A. There are already a lot of questions. And let's just start off with the first question here. How can we get more exact information about IBS epidemiology worldwide?
Yes, you see, this global study is a great step forward compared to what we had before, because this systematically checked and screened populations, more than 2,000 people in each country, either on internet or in door-to-door surveys. But these are still limited. For instance, what happened in my country, people over 60 underreported their symptoms because they simply, not so many people 65, 70, 75 use the internet. So in other populations like in South Korea or in Kenya, there are older people underrepresented because the population is more young. And therefore, we had some limitations, and the board of the study can agree with what I'm saying. On the other hand, we have few countries. It's a lot of countries, more than 30 countries, but anyway, many other countries in there are 200 countries. So many, even Austria is not there. So I think local scientific societies should get funds in order to be able to sponsor these studies. On the other hand, the internet survey has the limitation because we cannot check what the patients are reporting. So first, we probably should spend more time and money to include other countries in the future. And this can be also local initiatives. On the other hand, we can use also direct prospective checkups, consultations in order to be absolutely sure that the reports on internet and the field diagnostic criteria correspond to reality.
Okay. Thank you so much for that. We have a couple of other questions here. Is there a different probability to have IBS between male and female? So is the prevalence higher in either of the two sexes?
Yeah. So traditionally we know that IBS is more frequently in females than in males.
Yes.
That's no. In recent times, some studies shown that this difference is diminishing. But what we got now is that it's really true. Have you seen? It's not double, but almost double the frequency of IBS in females than in males. Why is this? Probably we have seen the history of disease, the hormonal profile, the physiology of the female bodies, which are predisposing this in developing hypersensitivity, in developing illness behavior, in developing symptoms reports. And I think this could be responsible for sex differences between males and females in respect to IBS.
Okay. So what is the difference between mixed IBS and unspecified type? Is there a difference?
Yes, mixed, it means that sometimes the patient has constipation, sometimes has diarrhea, filling the criteria. For instance, this week is more constipating, in 2 weeks has diarrhea, and many patients report this. A subgroup of mixed categories, the alternators, who may be stable for 1 year is with constipation or diarrhea, and which next year or in 2 years. While unspecified are the group who do not get the threshold of 25%.
Okay. Another question we have here about food intolerance tests. Do you believe in them, and do you use them as part of your treatment for IBS?
If food intolerance exists, then it's alimentary allergy. But people always try to get explanations for their symptoms. It was the traditional need you have seen by Avicenna proverb, we need to find the cause. And patients have difficulties in accepting that they may have symptoms in the absence of an original cause. And then they check, maybe I have parasites, I have giardiasis, maybe I have food allergy, maybe I have chemical polysensitization, and so on. People try different explanations, and therefore food allergy is real. Food allergy symptoms may interfere with IBS symptoms, like malabsorption symptoms may mimic IBS symptoms. But even ACG, you see, do not recommend emphasis on food allergy. The food allergy usually should be linked to certain allergies. People who believe that they have allergies, they maybe have FODMAP intolerance. They do not might have allergies. And this way to perform a lot of skin tests or so on, it's good, but not as a routine.
Okay. I mean, as you said, to some extent also, I mean, the disease can take quite a while. How long should patients continue with the treatment before you recommend that they try an alternative?
That's very, very good question, and maybe Dr. Rashid will complete my answer. Being a long life disease, this is what we have to explain to the patients. Some patients prefer to have cancer and to have chemotherapy and hoping to be ready. But this is a continuous condition, and they have to teach the patient, that's very important, that they have to manage their own condition. So therapy is lifelong, can be adapted to the main symptoms, because you see symptoms may change in time, but patients need to take care of themselves. It's like in hypertension, they accept to treat hypertension all lifelong. They accept to use insulins for diabetes all night long, but they do not accept to have bowel pains all night long. And I like what Douglas Drosman said, care, not cure. So we take care of them, being able that we will not cure them.
Okay. As part of the treatment here, we have an interesting question, I believe. Do you think that pancreatic enzymes are a good option to supplement or treat IBS?
Actually, pancreatic enzymes represent a substitution of pancreatic enzymes. To my knowledge, there is no data to support the use of pancreatic enzymes for IBS. However, empirically, I have seen patients who feel better taking pancreatic enzymes. They say, they say, lighter digestion, or I have less bloating. Probably bloating might have sense. So pancreatic enzymes is not in the guidelines, but if patients have a positive experience with them, I do not interdict this. Why not? If you feel better like this, continue.
Okay. If a patient is tested is not tested with celiac disease, so with IgA low, does that rule out having gluten intolerance, or are further tests required?
Gluten intolerance is actually present in maybe 1% of the population. Other conditions are as common, like bile acid malabsorption, again, 1%. But maybe 10% of the population in some countries eat gluten-free diet. They feel better, or feel healthier. It's like eating vegan or not eating vegan. If you believe that vegan diet is good, then you eat vegan. Okay, so in the absence of markers for celiac disease, it's not reason to eat gluten-free. But if some people want to do this themselves, they could. And people forget that FODMAP can produce, not the cereal, to produce the symptoms, the polyols.
Yeah.
So they believe I do not feel well because I eat with some cereals, but actually the FODMAP is important, not the protein of the cereals. Yeah.
Another question we have here, I will look at the time, but I think we're good for the moment. Can chronic pancreatic insufficiency constitute a subgroup of IBS-D, so meaning IBS diarrhea, of course?
No, not, but it's very important to discriminate, to differentiate from other causes of diarrhea. And most common are malabsorption, a biliary malabsorption, which is most countries is not checked, actually. We do not have SECAT, even in my country. Not many centers estimate in chronic so-called functional diarrhea, the biliary malabsorption. That's true. But pancreatic insufficiency, maybe in some geographical areas, might be more important if there are certain cases of pancreas, but actually it's not the let's say the main alternatives for differential diagnosis.
Okay. Does serotonin and ACTH play a role in IBS, as it's comorbid with fibromyalgia?
Very technical, very good problem. The person who asked me knows very well that several attempts have been done with serotonin modulators for receptor 3 and receptor 4, and they try to modulate constipation or diarrhea. The problem was that serotonin is also on platelets, and many people who tried allocetrone or tegaserol developed some peripheral thrombosis. So there are still hope, and some are coming back. Some of these drugs are now coming back. There is still a hope. Yeah, correct.
Okay. Now, how do you foresee the future of the disorders gut-brain interaction, taxonomy, and approach?
Yes, that's a difficult question. I'm not PTA from Delphi to foresee very correct, but I believe that future studies on brain imaging and on microbiota will probably lead to better knowledge of IBS subtypes and of different phenotypes, and would allow a better, let's say, approach of each cases. If this will be true, probably we will see evolving new subtypes of new categories of diseases. And Rome, soon people will start working for Rome 5, and maybe we'll see the advent of new data. And by the way, I have seen a question on probiotics in IBS.
Yes, that question has to be there, Dr. Dumitrascu, of course. How do you see the role of probiotics in treating IBS in general? I mean, what is your point of view?
I also use with great pleasure probiotics in IBS. Patients expect to receive probiotics in IBS, but the hope is greater than the proof for the moment. Why? One is our lack of knowledge. We do not have enough trials. And if we put together in meta-analysis, is somewhat disappointing. However, there are good evidence that certain species that I will not name here now are really useful. Unfortunately, what happens in the world, people say, I take probiotics. I take the first one that they buy in a pharmacy, or that the pharmacist is recommended. When we say, I take antibiotics, and then I take ampicillin, or I take, let's say, cephalosporin, or I take azithromycin, I do not say I take antibiotics. But my patients say, I used probiotics. So not specifically, we should use probiotics, but we still need to have more consistent data on each aspect, which probiotic, for which period of time, for each subtypes of IBS. So we have some data, but well, we do not have the golden bullet for this, or the silver bullet, how it's called.
Okay. Dr. Dumitrascu, here we have another one coming in. What's the lifestyle you recommend for IBS patients? I mean, it's a difficult question, but give it a try. What is the lifestyle you recommend?
Patients are different. So the patients have to adopt the lifestyle they feel appropriate. In fact, the life has to produce us pleasure. It's not for torturing us, to respect, to torture ourselves in order to be healthy. We have to compromise between health and our own pleasure. So first thing, this is a general recommendation, would be fighting or preventing stress, preventing psychosocial factors, There are techniques for relaxing. There are techniques to fight stress. There are mindfulness therapies, relaxation therapy, hypnotherapy. These are useful. So I think behavior changes might be useful. Diet, try it according also to the subtypes, diarrhea or constipation might be useful. Increasing social support, participating to patients meetings, keeping a good connection with a physician. These are all factors linked to lifestyle that could improve the capacity to stay alive and to fight with the disease.
Okay. So I have here now 2-3 more questions, and let's try to answer those. If the cause of IBS is giardiasis, a worm infestation, and
Again, if
the worm infestation,
giardiasis, I see.
Yeah, sorry,
Yeah,
pronunciation. Okay. What should be the dosage of antihelmintics, single dose or more, or is any other treatment required?
If giardiasis is really diagnosed, and we had a paper published in a journal called Science Environmental last year for 14 years population, then we have to cure it, but this is not IBS. The presence of parasitic condition is not IBS. If we treat it, single dose is good, but I will repeat the dose next week. If this is good, and symptoms, this parasite disappears, but the symptoms remain, we can consider a post-infectious IBS. And then it's true an IBS. Like it after traveler's diarrhea, or, in Norway, it was an epidemic of giardiasis, which was followed by IBS and functional dyspepsia. These cases. If after the disappearance of giardiasis, the symptoms remain, we can call it post-infectious IBS. Otherwise, it's simply a parasitic condition.
Okay. Now we have a lot more questions here, and I would like to finish off with one more for sure here, because it seems that there's a couple of questions going in that direction. Behavioral cognitive therapy. How does my child, how do I know that I should not go and see a psychiatrist or psychologist? So where is the intersection between the work of a gastroenterologist and the psychiatrist, psychotherapist in the assessment? And with that question, I'll leave that to you. I would actually like to finish off here the Q&A, and I'm sure maybe you can answer some of the questions in writing after this that are still keep coming up. And yeah.
Dr. I appreciate for your enthusiastic reception. So
yes, very much.
I have to say that working with IBS patients is the last 30 years. I developed my interest in psychosomatic medicine, and therefore I trained myself in CBT. So you mentioned CBT, cognitive behavior therapy. So myself, I can use CBT, but being a gastroenterologist, actually, I'm using this for counseling. I do not perform psychotherapy myself because I have another job, but I use it a lot. So CBT is useful. Everything is depending on the severity of the condition. And some patients need indeed psychiatric or psychological counseling. Others are coming to the gastroenterologist after visiting a psychiatrist for depression or for anxiety. Because have you seen on the 2 slides, an Italian paper, the anxiety and depression are risk factors for IBS, as well as IBS are risk factors for anxiety and depression. So severe cases need a psychological therapy, what's called neuromodulators.
Okay. Dr. Dumitrascu, thank you so much for your time. It was a pleasure and honor to have you here. And we shall now continue with a small presentation by our key sponsor, Eucarbon, the small little black tablets in the yellow box that I